Good evening and welcome to this meeting of the Adult Social Care and Health Select Committee. I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. This event is being recorded and will be available for members of the public and media to watch following the meeting. Now I would like to welcome you all to the Council Chamber at Kensington Town Hall. Before we proceed with the meeting, I would ask members of the committee and those who are also attending to ensure that your mobiles are silent or switched off. I think it would be appropriate for us to start with 72 seconds silence to remember those who lost their lives in the Grenfell tragedy. Thank you. Let's start with agenda item 1, apologies for absence. Apologies for absence have been received by Councillor Sam Makover, and Councillor Ahmed is running a couple of minutes late. Agenda item 2, declarations of interest. Does any member have an interest they would like to declare? Thank you. Agenda item 3, the minutes of the meeting held on February 1st, 2024. The action tracker and the meeting, does the committee agree to sign the minutes as a correct record? Okay. Yes, agreed. And sign the minutes. Agenda item 4, North Kensington Community-Based Recovery Service for Adults. This report updates the Select Committee on what's been delivered by services commissioned under the North Kensington Community-Based Recovery Services for Adults programme since April 2021. This is a really important service providing support for emotional well-being. We are delighted to be joined by 3 local organisations involved: Akava, Al Hassania, and Strengthening Kensington Young Families. Please could you all introduce yourself to the Select Committee and please, yes, speak to the report. Thank you so much for coming. Sorry.
Chairman, would you like me to introduce the report before you introduce our guests?
Yes,
perhaps that would be easier.
That would be great. Thank you so much.
Thank you, Chair. And yes, I would like to introduce this report to update the committee on where we are with our adult mental health recovery services in North Kensington post-Grenfell. As you'll see from the report, we provide commission a lot of services through community groups, which are present here this evening, to talk about how helping the community, obviously in the Grenfell Recovery Programme, and how we can look forward to views and scrutiny from yourselves on any questions that you may have on that particular instance. As you'll be able to see, we do have some figures on page 20 of the report that looks at how many members of the community the organisations are supporting and how people are feeling about the future and other services that they may wish to see or not. As you'll see as well that the community groups as well offer a range of services in a range of languages as well, who are also culturally appropriate for members of the community who are accessing those particular services. But as I said, I'm really happy to take questions on that as well, in addition to Gareth here, who's our Director of Commissioning in RBKC.
Thank you, Josh. Do you want to add anything? We'll go straight to...
Just to add, Thank you, Chair. You'll have seen from the report that there are kind of two key components, I think, to the way that these services are commissioned. And for a number of years now, we've had talking therapies provided by three organisations now. Al Hassaniya here this evening, Al Manar, and Midai, who provide those services and have continued to do so. And then for the last 2 years, we've had peer support programmes in the run that we've been able to fund through this programme, and also through learning from other sites of major tragedies in Manchester and New York, knowing that those peer support projects can be really helpful. So we've got our commission providers from some of those organisations here this evening too.
Thank you. I don't know how, Beth, do you want to sort of come in one by one from the left and add? Yeah, I'll let you, if you sort of speak for about 2-3 minutes, but thank you so much for coming.
Hi, thanks for having me. My name is Rasha and I work for Akava. I am curator of makerspaces for Akava, and one of the makerspaces is Maxilla Menshed. So we are a makerspace that's based in North Kensington, just under the Westway, a stone's throw away from Grenfell. It's a community makerspace, so that means a lot of things. Initially, we were funded, we started in 2019, and initially we were funded by the NHS, and that was to tackle social isolation and loneliness and to engage more men in our community. But we have an open door policy, and everyone from our area, North Kensington, is welcome. Through, I guess, the Peer Support Fund, which is what you guys really want to know about, this helped us design some courses, and over, I think now we're going into our 6-month extension, so it would be 2.5 years. The first year we ran 8 specialist courses to skill up members of the community, and that was all based on various making skills from our makerspace. And then the year after that, so last year that just went by, we ran 8 courses which were all designed around the circular economy. So we were challenging artists and facilitators to rethink their process and the circular economy, as well as teach these skills to our members of the community. And the way all the courses were designed was that, so we have a kit, we invest in a kit, because there's nothing worse than learning how to, for example, become a leather maker or whatever the skill is. There's nothing worse than learning these skills and not having anywhere to carry on with those skills, not being able to afford the tools, not having a space where you can be messy. And so everyone who came to our courses was then referred to our tinkering sessions, which is all year, every week, all year long. And yeah, everyone's welcome to come and tinker in our space. And I guess the course helped different people for various things, but I think one of the biggest things that was fed back to us at the end around Christmas time was that, well, first of all, our space became a leather working factory, and I think the biggest thing that was fed back to me was that it changed their Christmas. That Christmas wouldn't have happened because it wasn't one of the things we were aiming to target, cost of living crisis, but it was. So as well as skilling up and a lot of people feeling valuable with these skills, I guess it helped with that, and that was great feedback. I think one of lots of different feedback, but one of the things that stood out the most was that it helped with their Christmas, amongst other things. Happy to answer any questions if you have any.
Thank you so much. If we keep going speaking, then we can get to the questions and the committees can ask you anything that's direct. Thank you. Oh, no.
Okay. Yeah. Hi, thank you very much for inviting me here. My name is Iman Bouzir, and I work for Al Hassaniya Moroccan Women's Center, who has been providing a variety of services to support the community, but the psychotherapy service for Arabic-speaking women was born out of need since the the tragedy of the Grenfell fire. So we created, through the Together for Grenfell project, a unique service which is designed for Arabic-speaking community. We identified a gap in the provision. That a lot of people were not accessing the mental health provisions that were there for them. So we kind of thought of designing a unique service for them, mainly to help them access those services. We understood that there were some barriers, but we wanted to understand what the barriers were, and we identified that there was language barriers, a mistrust of statutory services, including NHS, a lack of awareness of mental health, psychological support, the stigma attached to it. So once we understood the barriers, we were able to provide culturally adapted mental health support for them. And so the therapy was delivered in Arabic, but also delivered in French. I myself come from a multicultural background, and it was very important for the service users that they are helped by someone who matches their ethnicity and they have understanding of the background. We addressed the language barrier. And by offering one-to-one long-term therapy or brief therapy trauma, we adapted the mainstream trauma provision to meet their needs. We also offered a lot of variety of different services, such as trauma therapy, group therapy. We created a model in cooperation with the NHS. We collaborated to provide a model that worked for this part of people. So we understood that maybe the NHS were not, they didn't have the belief that other ways would be working. So there's some sort of disbelief that only the mainstream way works, but we kind of challenged that by offering something really unique to people, and we listened to their needs and we did what they want us to do for them. So, and it worked. So the feedback that we had is that people were accessing those services. We did groups where we offered different activities such as choir, cooking, which was key for the community, gathering over food. We did MDT, which is music and dance therapy, as a tool of expressing emotions and feelings, and that also worked. So we were quite creative and trying different things that people were telling us they wanted to do. The outcomes that we engaged people, we overcome isolation. The feedback was that people were really enthusiastic and excited to come to the therapy groups that were provided for them. Didn't have to worry about not understanding mental health. So in a way, that we created a working model and sustainable model that really worked. Thank you.
Thank you so much.
Is it my turn? Good evening to everybody. I've made a list, so I'm just going to go through that, if that's okay. My name is Abdurrahman. I've worked in the borough for literally 25 to 30 years in youth work, and basically being a manager for a community centre as well. Just during the pandemic and after, I started my own youth services simply because there was a lack of youth services in about 5 sort of like areas in the community. We started a project which was funded by Sports England called Men Matter. It was all about young men who are being affected by Grenfell and going through a lot of PTSD. So we thought, let's bring everybody together literally in a safe place. Main things that we started with in order to tackle the situation of the actual MH, which is mental health, is getting physical activity together to relieve stress for young men. Boxing, Muay Thai, football, everything else that comes together. So it's 18 plus young men. Did a lot of work with collaboration with Community Living Well, which is part of the NHS, and they are in St Charles Hospital, which literally brings in a lot of affected young men through the mental health services. So we basically connect people who have got situations into that service as well. Working with Mind, counselling therapies every 2 weeks to come in and actually have a talk about all kinds of levels of mental health and educating young men about mental health and its issues. Health Watch as well, which is based in Westminster, they did like a project to literally tackle, yet again, mental health for young men in Westminster and RBKC, so we worked with them. We did outreach work in order to find out, what the cases in our community and what the effects were. Kind of subjects that we're talking about affected in our community is suicide prevention, depression, loneliness, relationships, finance. Drugs is a big situation in our community where young men do fall into this and end up with very high mental health situations, and having to literally deal with that takes a long time. So we started a thing called walking therapies, where our staff would actually just anybody who wanted to take a walk and talk about their situations will be able to actually do that and to see if they can come out of the problems that they are in. Domestic violence and abuse was part of the actual mental health that we found, and we're trying to tackle all of those problems. At the present moment, we are reaching out to the refugee, and we've worked with the refugee and asylum seekers as well, young men who have been placed in the borough, who literally are just in hotels with not much going on. So we've been offering them the service in terms of, like, when we worked with them as well, physical education first, and then we'll go through to basically do other stuff with them to offer things for families as well. The outreach is actually, we did an outreach program 2 weeks ago, again, every 3 months, and that's just to, yet again, find out the things about people in our community, what they found, have they been, solved, sorted, or anything else that goes with that. Any questions, more than welcome.
Hi, my name is Harry Black, and I'm just here to give a bit more information on what the Youth Club does for young adults like myself. And that's all really. If you have any questions, I'm happy to answer.
Thank you so much for all coming here, and it's amazing to hear what you're doing and the work within this community. I think we will start with some questions. Portia, you're...
Yeah, thank you, Chair. Thank you for coming. I must say, I was a bit annoyed reading this report. I know of great work this gentleman does within our community, but as a councillor living across the road from Grenfell, how wasn't I aware of T4G all these years? I think that's one question. 2, what are the pathways to your service? Because I'd like to refer a few residents. I know what you do. And also, what I would like to know is, in the council in 2019, is anyone taking note of my questions? 2019, 9th of January, the council was committed to do a Grenfell recovery strategy. Is this a part of the piece of work? To work in partnership with local residents and for it to be community-led? Is this a part of the work? Now, when you look at the list, you see 3 Muslim organizations, which is great. North Kensington, how many people in North Kensington were traumatized by the fire? Over 8,000 to 11,000? We were engaging with 400, 500, 600 here. What about other nationalities, cultures, and faith groups? Yeah. No.
Sorry. Just, we're going to go to Josh.
No,
and Gareth
it's
first,
not
and then-
necessarily you. It's leadership I'm talking to. Okay. You're doing very well, I know. I would just like to know, because you see, the African Caribbeans, again, they've been left out in the cold. And I would just like to know, what's your pathway to service?
Yeah.
Thank you, Councillor Thaxter. No, I think that's a really, really good question. And on your first point about the promotion of Together for Grenfell, I think is a really good challenge. I think from some parts of the community, absolutely it is well known, but evidently not all parts of the community who can potentially access the service. And like you said, there are still people traumatized. Obviously, we're coming up to the anniversary in the next few weeks. We're having the publication of phase 2 of the inquiry in the next few months. And obviously that's going to cause more concern and more worry in the community on the basis of what those two particular events are going to do. So I think together, that's a really, really good challenge. And I think we need to do better, of course, as a council in promoting that as well. And I absolutely think you're right that perhaps we haven't done the best job in that. I'm going to get Gareth to come in here to speak about the specifics and operations of that. But compared to the other services we do, for example, like the children's services that we have in all our schools, etc., I think that's probably much more well known than perhaps these, and that's a really good point on that. On the second part, the 9th of January 2019, regarding the Grenfell recovery strategy. As you know, we have done lots of work with the services that we provide to the Grenfell affected community, or all of North Kensington, not just those affected, bereaved and survivors, through our Grenfell team. Obviously, we have the dedicated service, we have all the issues with all the children's services we provide, we have all the programs with adult social care. We work with all the partners, NHS especially, from that too. And there is, as far as I'm aware, working really hard from our Director of Grenfell Services, Callum, who have been working on that. What we'll do is probably get you more details on that. I don't have them directly to hand, but as far as I'm aware, we do have a strategy for recovery for Grenfell. But again, you know, that's something that we can follow you up on in writing, and get Gareth to come with that in more detail. On your third point regarding community-based provisions for perhaps other sections of the community, Caribbean community, looking at other people, church groups and other faith groups by providing the service as well. Again, I think that's something that Gareth can come into and we can look at as well. I think it's a really good challenge. I think perhaps the people who access the service are from affected communities and affected communities that need the help. And I think the community organisations here have done an amazing job. And I think what they've done, especially on some of the results here, have been absolutely phenomenal. But I think for the wider challenge from other parts of the community as well is a really, really good point and really good challenge. And hopefully that's something we can look into and change. But I'm going to get Gareth to come into that and speak to that in more detail from an operational perspective.
Thanks, Josh. Sorry, Councillor Rendell has just explained, these services have been part of the Grenfell Recovery Programme since the outset, since they were first commissioned. So particularly at the earlier stages, the Together for Grenfell collaborative of organisations formed part of that wider suite of support that the council put together overall, as Councillor Rendell says, from the dedicated services, from an equivalent group of commissioned provision for children, young people and families, whereas this group was specifically focused on, as Iman said, an identified adult need in the area where people were unlikely to or uncomfortable accessing mainstream services at that point in time. These established, trusted local organisations provided a route in from that. At a subsequent phase, a number of things that I think reflect your question led us on to broadening out the offer to the peer support organisations, of which Akava and Skyford too here speaking to us this evening. Part of that was the learning from other sites of tragedies, but also part of that was in response to knowing there were some groups that hadn't come through to some of the existing organisations. That in particular was men, and it was also in particular older residents. And as you say, so some community groups that hadn't accessed some of the existing services. So in that first year of the peer support programmes, 6 organisations were supported to deliver, and then in the second year that has extended to 13. So we can share the list, but there's a broad list which would perhaps reflect a bit more what you're describing there, the diversity of the community. And how people are accessing that. We actually have our regular provider forum tomorrow of all the organisations, and you'd see there kind of the range of different kind of provision and access that people have. In terms of how people are referred
Yeah.
in, that can come from a range of sources. I think primarily that comes from within the community, where people know each other and will help. There are also referrals in from health services where a mainstream health route might not be the most appropriate one, but actually maybe if I invite some colleagues to talk about the way referrals happen for them, that might be more helpful.
Hi, good evening once again. Portia, thank you very much for highlighting all that information. To be honest with you, I don't refer myself as a Muslim organization as such, so we are diverse. And on our Instagram page and website, you will see the diversity basically in our organization, the type of young people that basically come in. On the ground itself, when we are doing our work and outreach, I think Harry's an example of a young person. He's 20 years old. He can explain how he was basically connected and was told about the youth club in order for him to come in. So on the ground, it's always word of mouth, our Instagram, websites, anything that we can get our hands on to literally get out there in the public to speak to everybody and bring them in. That's how we basically work on the ground. But I think the community does not see itself as it's a one faith or nationality. I think it sees itself as a diverse community where we all get together no matter what. So yeah, that's my saying.
Thank you. Another question, but I will comment on what you said. You know, people are alike. They're governed by their environment, and they do go where they feel comfortable. And I'm not saying you're not doing great work, and I'm saying great. We're covering, you know, your cultural aspects of it and your faith, you know. But what about the Christians? What about the Sikhs? What about, you know, we have to look at things from a collective point of view in order for us to capture. We've got 8,000 people that are traumatized in North Kensington, or maybe it's 11, somewhere along that line. So it's if we're going to go out and spread our wings so that our work, you know, efforts count, I think we should just do so and work collaboratively together. And also my question to this lady here.
Sure.
Yeah, you mentioned that you reach out to men, and I would just like to know, what would you do different considering the uptake is so low in terms of engagement? What platform are you using to engage these men, and how can we help you to do so?
Thank you.
Sorry, when you say the platform is low in terms of engagement,
The intake on your report, you know, of engagement, the men.
it's low for our specific program.
Uptake for the whole program.
So I guess it depends on what you mean by that, because our programs are designed for specialist courses where it's not for lots and lots of people. It's for a specific amount of people over a long period of time to learn that skill. But the way the shed is designed, so those are the courses, this is what this strand of funding does. And then the shed's open to everybody on regular days during the week. And the whole idea is it's shared skilled space, so that a lot of the people on the courses tend to come back to the shed and tinkering session, and then everyone learns from everybody, and that's kind of how our program's designed. So it's not designed for like massive numbers of people, the courses. It depends on the artist facilitator and their capacity or what the course is. So for example, if you were teaching carpentry, it would be super expensive to engage more than a certain amount, because we'd have to buy an excessive amount of tools per person to do the course. Is that answering your question?
I'm confused because we're working on a recovery strategy.
Pardon?
I understand your service delivery process.
Yeah.
But I'm quite concerned if you've got a specific number for you to engage with. So who else is taking up the rest if you've got such a large capacity to engage with in North Kensington?
Portia, can we go to Gareth, because I think he will have something
So there's
to say on this.
so the Men's Shed project that Russia's describing there is one of 13 of the peer support projects, alongside the 3 organisations that provide the talking therapies. So expanding this 2 years ago to bringing the peer support projects, partly that was to bring more people in who might not otherwise come. And if you look at the table just below paragraph 525 in the report, that shows how those numbers have increased by us increasing the investment so that there are peer support work happening too. So in the talking therapies, it moved I think from 500 one year where there had been additional funding to 300 people accessing the talking therapies. And then when we brought in the peer support projects, they're seeing over 500 individuals supported per year across the range of the 13 different organisations and projects that are delivering for it. So those numbers have done what we wanted them to do in terms of increasing access and helping more people to get support.
Yeah.
Okay, thank you.
Portia, I'm going to move it. And we're more here to scrutinise the kind of council's position on this rather than our organisations who have come here tonight. So I just want to make that clear. Mona, do you have any questions you want to?
I guess the question I had really was, I mean, these are outcome figures that any intervention would dream of, really, 98% positive feedback. I just wanted to hear a little bit more about how that was measured. You mentioned qualitative and quantitative, so just to hear a little bit more about that. And is that specifically for the talking therapies or for the peer support interventions or both? And I just had a couple more questions about the counselling service, but perhaps we can just answer those.
That was in particular to the counselling and wellbeing support and therapy. So there was a use of a wellbeing measure, which we worked together with the providers with.
Can you speak into your mic if you lift it up towards your face?
Sorry,
Thank you very much.
Sorry, is that better?
Sorry, Shazia, could you give your name and title as well for the committee?
Yes, I'm Shazia, Head of Care Markets for Integrated Commissioning. So these services sit within our commissioning portfolio. So the feedback was sought from in particular the counselling and wellbeing offer, the counselling sessions. We used different measures of wellbeing scores, some things like the Warwick measure, but actually made that more specific to the communities in which we are working to make sure they were meaningful. So there were a series of questions that are asked of people who, when they begin accessing the counselling and wellbeing offer, whilst they're going through that process, and also when they exit that as well. Iman may be able to talk a little bit about that, but that was a measure of how people felt and what they wanted to achieve out of it, the range of support that they got, and also about how it improved their skills or their perception or meeting their needs as part of that. So that's measured across a little bit of the life course of the services and the support that they get in that offer.
Thank you. And what exactly is the life course? So 330 people accessed the talking therapies, it looks like. So was that a course that they accessed, or was it one-offs?
So it would depend on which provider we're working with in particular. So for some providers it can be a series of 12 to 16 weeks. For some it was a little longer, and at the most it was up to a year, depending on the type of support they needed. But it would be as part of the ongoing process that the discussion very early doors around your support is for a period of time. Often people were referred in from GPs, or they could be from the Grenfell Health and Wellbeing, or they self-refer in to get support. You didn't have to go through a statutory assessment, which was part of the draw of this service. And people could exit and may come back to the offer over time, but there is a period of time that's assigned to it.
Thank you. Yeah, I just wanted to say I've met some of the women who offer the psychotherapy at Al-Manar and was, extremely impressed by just how knowledgeable and sensitive they were.
Thanks, Mona. Jarrett, do you have any questions?
Thank you, and thank you very much to the people who came to present. I know many of the organisations and the great work that you do, so thank you. Looking to the future now, really. Para 5.33, you mentioned the new arrangement council consultation. I know it only ended on the 12th of May, but any initial findings of that? And maybe interested from the presenters, any lessons you've learnt over time that would be useful, sort of reflecting on how we go forward? But Gareth, do you want to just, is there anything to report on that so far?
I think I'd be stepping out of my role a bit if I was kind of talking too much before the end of that report and the full findings and recommendations. However, we are working with our colleagues internally in different teams, adult social care, public health, children's and communities, as well as our partners in the NHS, to look at ways that we can support particularly the Together for Grenfell organisations on an ongoing basis, and have been working with them over the last year, as was done before the most recent round of funding, on transition plans. So how some of the services that have been in place and are still needed can continue to be supported in the most appropriate way following the outcome of this kind of period of funding. We are very likely to continue a round of peer support funding for at least another year, but for the core talking therapies, we'll have to kind of wait to see the full outcome of that. But rest assured, we're taking kind of all steps that we possibly can to look to way to continue to support that, both ourselves and through partnerships. And I think it mentions in the report where some of those organisations have been successful in accessing funding from elsewhere through routes like the Big Lottery Fund.
Quick lessons, yes?
I mean, just to say that I'm also born and raised in North Kensington. It's also my community. And I guess what I want to say is just longevity. I think like when you look at social isolation and loneliness, or you look at our traumatized community, building trust takes a long time. They have survey fatigue, they have consultancy fatigue. These are all barriers that we have to constantly kind of put time into, and yeah, all I want to say is longevity, looking at long-term kind of funding where we have the opportunity to build those relationships and work harder and, yes, engage with all members of our community. And core costs, just want to mention that, it's super important. Core costs are super important, so it's part of, becoming sustainable long-term. And yes, different strands of funding are great, but different strands of funding have different criteria. So we're constantly rebuilding and shifting and adjusting. So yeah, that's it really.
I'm just going to go to Anne, then I'll come back to you.
Is that working? Yeah. Thank you to the organisations for coming and for all the work that you've done. And I'm really familiar with this part of the recovery programme, and I know how powerful it is. So I also wanted to stress what Gerard said about continuing to support these therapies and actually even more than that, integrating them into the way that the council works. And that was the whole idea. When the Grenfell recovery was developed, as you know, it was about doing things differently and providing services that really do speak to people, in the way that they want to be spoken to, rather than a sort of one-size-fits-all. So I really do know how powerful it is. And I feel, Gareth, it's so important that these learnings are captured and we use them, and they're used for many, many years, and we work with these organisations. So just to put it's the same point that Gerard made. And I also wanted to ask Harry if he would mind telling us a little bit about his experience, because I think the service users, it's such a horrible phrase, isn't it? Because you're a person, obviously, but just so that people can really understand, the difference that this programme has made to people like you. So if you are comfortable to speak to us for a little bit, that'd be really great.
So I'm a care leaver, and I think throughout my life I've definitely dealt with quite a lot of stress. Since coming to the youth club, it's definitely helped a lot. I think going on talking therapies, it helps. Coming down to the youth club, meeting other young kind of men, and we can all share kind of different ideas, and I feel like they relate as well, It's like when I talk about certain things, I feel like maybe older people can't really relate sometimes. So when I speak to young men like myself, it can help. And I think it's quite hard, like especially today, in this 2023, it's quite hard, 2024, sorry, it's quite hard to meet people. As a young man, I struggle quite a lot to meet people my own age. So it's definitely helped. Thank you.
Mona, I'll come back to you in 1 second. I'm just going to ask her. I think we've touched on this before, but we know that the uptake on men using the service has been much less than other groups. And focusing in on dedicated support programme for men that began in year 2, and I think I'd love to hear from you, could you talk to us a bit about how effective this programme has been? And this does very much touch on, Harry, I'm sure, what your experience has been and if you've been feel it's making a difference to the men that you've worked with, and also just generally how we can apply that work to our work within the council around mental health, particularly with men, as we've got a working group coming up that will be based on this around suicide prevention. So work you think has been effective that could be applied, particularly with male groups, I'd love to hear. So, yeah.
When you said to talk about my experiences, can you kind of give me an example of like experiences in terms of support?
Your experiences of support, I mean, you've just touched on it, but just has anything helped you in particular, or any organisation support?
I mean, first of all, I think it would be a bit personal to talk about certain things.
No, don't do it.
But yeah, the talking therapy, I think that's helped me a lot. It goes hand in hand.
Yeah.
Yeah.
Or any, I think, Rasha, I'd also love to hear from you on this. All of you.
I mean, it's a lot. There's a lot of work that goes into engaging men and all members of our community. It requires taking a lot of time to understand all the different kind of demographics and age groups, etc., etc. But in particular with men, I mean, one of my shedders is here, by the way, John, which is complete coincidence. I didn't know he was coming. But yeah, for a lot of our men, I think it's the processes that are involved. It's the labeling, it's the language. It's working very hard to change the language. Like I said, everybody has survey fatigue. It's about having the time to build these authentic relationships, to build the trust. And that just takes a long time. And that's the main thing, I would say. I think for us, it's been consistency as well. So we run our specific days, Tuesdays and Wednesdays, and anything that changes from that is quite difficult. We find that although men engage in the courses, the courses we've run with these guys, with the Peer Support Fund, and they do engage, but they engage more in our tinkering sessions, where there's less commitment, there's less wanting to take up a space and let us down in case they don't turn up to the whole course. They prefer coming to the tinkering sessions than the courses. Some of them still come to the courses, but we have a bigger uptake for the tinkering sessions. So I'm going to say consistency. Yeah. The fact that it's happening all year long. I'm also going to say open door policy works really well. I mean, that's quite a challenge in itself because we're not necessarily collating all the data that funders need. But open door policy allows people to drop in and they're okay with coming just for 5 minutes if that helps them get out of bed. And also celebrating what's valuable to them. So in particular with men who have retired, a lot of the time it's about celebrating their skills and also understanding different cultures. So my dad, some of the language that's used in some of the systems to recruit or to engage, my dad would find that a bit insulting. Some of the kind of, how happy are you? You can come. How happy are you now? I mean, these are all things that we challenge and we change and we design new to engage men. So it's a lot of things. But anyway, I hope that helped.
Yes, if we can keep it brief, because I'm also conscious how many people we've got in the room tonight to get through this agenda. Thank you.
So just wanted to add to what Rasha said. Although we are referred to as Women's Centre, we at some point encouraged men over 55 to attend our mental health awareness group, especially for Arabic-speaking men, because we identified that lots of problems that the community are going through coming from a lack of awareness and a lack of understanding of mental health symptoms and issues. So what we did is we ran group for Arabic-speaking men, and we helped them to understand their mental health. So, some of them, they were depressed, they don't understand what depression means. They've been raised to believe that men shouldn't cry, that they need to suppress their feelings, and it's hard for them to open up and access mental health provision when it's needed. And therefore that impacts the whole family's dynamic. So by providing monthly workshops, they were able to help their own kids as well, because they had some of them had some adolescents who were struggling with mental health but didn't understand how to help them. So and they were, the feedback that we had, that they were very surprised that they've been suffering in silence for so long until they started attending those workshops, when they had some sort of understanding and where to go when the help is needed.
Thank you very much. Yes.
Yeah, hi. On your questions about men, obviously, services, through, being funded through the Grenfell, obviously, peer support program and so on, having to do quite a lot of collaboration actually worked well, because with the NHS, we started a new service for a platform for men only, and it's called Men Health and Wellbeing Platform. And what we did, we went out and actually connected to, let's just say, the personal trainers in the gyms, anyone who felt as a man wants to come onto this platform, GPs, for example, Chelsea FC, Community Living Well, personal trainers, GPs, counsellors, as men, to speak about men's issues on a platform and to see how we can support those people going through bowel cancer, any kind of form of situations that men can go through. So if anybody or anyone wants to basically jump on, I'll give you the connection. Yeah.
Thank you. Mona, do you want to?
Very brief. It's a question really about the retention of the counselling service. So it looks as though next year at least the peer support work is safe. And I was just wondering how confident we are that the counselling services can also be retained into the next phase, and what support is needed from the council to ensure that, and whether other funding streams have been considered, such as from the NHS.
Yes, in answer to that last question. So we've given the nature of those services, and that the NHS has been involved throughout in the design of those services, in their accessibility, etc. We are talking to them at our provider forums and outside of that about ways in which the lessons, I suppose, from the way that Iman and colleagues' services have delivered that might be taken forward. We're also looking at ways that elements of what the services have done that are kind of mental health talking therapy related, but also kind of the wider community support role, also help to fulfil some of the related ambitions of our other commissioned services. So we might be able to make some use of that through the mainstream provision, as Councillor Siren mentioned earlier on. So things like we have, we're just completing the procurement of a new integrated healthy lifestyle service, for example, which is a kind of structured programme around weight management, physical activity, stop smoking, that is currently contracted out to one organisation. We're going to have another one. Some of the things within that we're doing in the new procurement is about having a much more targeted offer, working with community organisations, so that we can reach groups that haven't necessarily been accessing that service in the past. So there may be opportunities through our mainstream commission services like that to learn the lessons from what's been commissioned through this sort of programme previously, and continue to be able to deliver some of the elements of it. In terms of the scale of how confident I am, I'm not sure. As I kind of said in answer to Councillor Hargreaves' question, there is the outcomes of the consultation will be shared at the end of this month with a series of recommendations about how that funding can be used in future. In the context of that, then at that point, I think at the end of this month, we'll be able to say much more clearly what could be delivered through that, and then what else we might be looking to support through other means, whether that's through some of our existing mainstream commission funding and or through organisations like the NHS, Big Lottery, etc.
Thank you so much. I think I just had one last question to Josh and Gareth, which was, I appreciate that the model of how this works is going to be changing, and the areas of services and support that don't get carried through to the new model but maybe worked very effectively. And you can tell me if I'm getting this completely wrong. Is there any chance that they can still be run within the council, or we can sort of push the learnings forward from those services, even if they're not in this model, in future work that we provide?
It's a good question. Gareth can correct me on this, but I don't think we can run it because I don't think we're allowed to provide any healthcare services at all as a council. We always have to commission those out to relevant people. But we do have the refreshed Grenfell JSNA report coming out shortly, which is due to come to the Health and Wellbeing Board on the 18th of July, which will look at the recovery program from a particular health point of view going forward. And from that point, we'll look at what particular next steps may be needed going forward as well. As I mentioned at the start, I'm conscious we've got the anniversary coming up shortly, and the Sir Martin Morbick's inquiry report coming out as well, which will have an impact on the community as well, no matter what that report says. So with that, with the JSNA and the next steps that Gareth just referred to, we'll certainly take a look at what that is. Can't commit to it now because we just don't know what that is in there.
No,
but from that point onwards, it's a really good challenge for us to look into.
Thanks, Josh. And I just want to check if anyone from members of the public want to ask any questions, but I don't know if we actually have any. So I'm going to draw this item to a close, as I think we're all assured that services run effectively, and I think we'd be really interested to talk to you further about particularly services that you're providing for men as our working group starts in the coming months. It'd be great to come and speak to you. And thank you so much for coming and speaking tonight. We really, really appreciate your presence. Hi, yes. Oh, can you put your microphone on if you press the red button? It should light up.
Rasha, I'm well acquainted with her work. She does a lot of fantastic work for us, and she does it all with a smile. She's a cheerful person to have around. I'll say I'm quite disturbed by a lot of the Grenfell support. It was wonderful for a while. I had someone, but she left the service, and she's never been replaced. And I'm in a phase which I'd call pass the parcel. I've been to all the support institutions, but whether it's because I'm elderly, I mean, I'm only 77, but, you know. And I think supported housing, it is not, there's some unsavoury aspects and things. It's deteriorating. If you could give me someone who would like to address these issues, perhaps ward councillors, I would like, they have me, they have my time. I know buildings, I know stuff. I was a carpenter for 40 years in construction, and I know my way around these places, and things could be improved.
Thank you very much. Are you happy for us to connect you with the relevant person to be able to contact you about this?
Absolutely.
And then, yeah, thank you. Sorry, only as we've got a very full agenda. But what's the best way to?
Yeah. The three guys, Claire and Marwan, yourself. You're delighted. Yeah.
Thank you so much.
I have been involved with future neighbourhoods. I've been involved with these, trying to focus on the old people. A lot of people disappeared after COVID. They just didn't make it through.
Thank you very much for coming, and I'll get your details from Mona, and we can connect you with the relevant. Thank you very much. Moving on to agenda item 5. Thanks. Sorry, everyone who is moving. Which is update on GP same-day access hubs. This recent This report provides an overview of GP same-day access hubs and patient access. We agree with the NHS that access is the number one concern of patients. However, there is a concern about how changes to access will work in practice and what this means for patients. The Select Committee recognises that primary care is the front door to the wider health services. So it's important that any changes improve access but don't affect continuity of care, particularly for vulnerable patients. We're joined tonight by our borough clinical directors, Healthwatch, and 2 GPs who work in the borough. Please could you all introduce yourselves to the Select Committee? Thank you.
Hi, good evening. My name's Simon Hope. I'm the Borough Director for West London.
I'm Dr. Andrew Steeden. I'm the Borough Medical Director and also a GP.
Joe McGale, Assistant Director of Primary Care for West London at NHS North West London.
I'm Dr. Nikki Dangel. I'm a GP at Colville Health Centre and a director of one of our local PCNs called Neo Health.
Hi, I'm Dr. Yasmin Razak. I'm also a GP at North Kensington.
Cleo Chalk, I'm the Service Manager for Healthwatch Westminster and Healthwatch RBKC.
Thank you. And can I ask, Andrew, are you going to introduce the report, and then I will come to Nikki and Yasmin afterwards?
Thank you very much. Thanks very much for forwarding your inquiries before, and hopefully the paper you'll have had the chance to read answers the meat of the questions that you asked. But so I won't go through the paper so that we have more time for questions later on. Just to say that the North West London Access Programme is a response to COVID and an attempt to try and help the NHS recover from the COVID pandemic. It is a North West London programme, so none of us around the table are leaders on this project, although we do lead on the local implementation of North West London policy. So I know that at the JOSC, you will have had an opportunity to ask some of the strategic questions around this programme, and I'm sure you'll get the opportunity in the future as well. But we will try and answer as many questions as we can about how it affects us here in West London. The North West London is trying to address access, as is the whole of the country. And there was the Fuller Stocktake report, which looked at healthcare services after COVID, and she came up with several pillars around how do you address continuity of care, how do you address access, and how do you make good use of resources to keep populations healthy. And there were a number of recommendations that she made, and reviewing how we delivered same-day access was one of them. So North West London is looking to see how it can address variation across North West London. Fortunately, here in West London, we've had a much longer programme of addressing access. Partly, as it's hinted at in the paper, we had slightly more finances than other bits of London, so we were able to invest in primary care and in PCNs in a way that other bits of North West London didn't have the opportunity to do that. That means that with the support of our PCNs and CDs and our local GP Federation, we've already been trying to improve the community's access to primary care through a number of schemes which are detailed in the paper. And I think what that's reflected in are relatively good patient satisfaction results around how they view their GP services, and particularly how they view the access offer. Now, nothing is perfect, and we know that there's huge variation underneath those relatively good numbers. So we know that there's a piece of work that we need to do. So we will be joining with North West London's work around reviewing how we do access. As I say, we already do a very good service, and lots of the things that were proposed in the North West London programme we're already doing to some extent in West London. We're doing access at scale, we're doing weekend and evening surgeries, we're doing a home visiting service, and we're offering extra appointments. There was a degree of concern that was raised around the initial proposal in North West London, because there was an initial intention to join the access programme to a part of the GP contract. That caused a lot of concern because it implied that GP services and access was going to change, which in fact wasn't the case, but because it caused that concern, that proposal has been paused. And so we are now redeveloping the proposal so that we're going to have a period of supporting PCNs to negotiate with their communities, with their patient and participation groups, to see exactly how their access is being taken up, to decide what issues there are, and to come up with a programme for dealing with those. And we will be monitoring that as we go forward over the next 12 months or so. So that's probably as much as I probably want to say at this stage.
Thank you very much, Andrew. I'm going to bring in Yasmin and Nikki, who can also add their thoughts to this. Nikki, do you want to go first?
Thanks, Andrew. I mean, I think that the paper does detail really a lot of the work that has been going on in practices and PCNs across West London since COVID, and then really, I guess we've all been ramping it up really over the last year or so. There have been some big changes in many practices to really try to address the difficulty of getting through to the practice, getting an appointment when you need it and with who you need it. And although we all acknowledge that there is still a degree of variation and a lot of work to do, there is a lot of commitment across West London from the clinical directors of all the PCNs to really try to standardise and reduce that variation and make access, I think, I think we are all committed to making sure that access is the biggest priority. We are supported massively by a lot of the other work going on across West London. The GP Federation appointments are supportive. We have a home visiting service, as Andrew Steeden said. So overall, there is a journey. Many practices are well on it. We are all committed to making sure that all practices are on it. And I think that there is a desire for practices to be able to see their patients, see their own patients when possible. I don't think that there is a need or an appetite for patients to have to be seen particularly, we don't want to separate patients' care. I think that's really the biggest thing. That's what I'm trying to say. We are committed to making sure that patients' care has all the continuity that it needs for them to be seen safely and for them to be satisfied with the care that they're getting.
Thanks, Nikki.
Hi, so thanks for inviting us to speak. So as I said, I'm a local GP, and me and Nikki happen to represent only one part of our borough, so I hope it's useful that we are able to come and talk today. I think the first thing to say is the paper shows what high-performing surgeries we do have in West London, and it's really nice to see that, especially the north ones, where we do have higher deprivation. In fact, out of North West London, the 3 north boroughs are in the top 10 actually for deprivation in North West London, which you don't normally think about when you think of RBKC. So actually very highly performing practices, and that does go down to the good relationships that we have with our commissioners and the impact of the fine-tuning of the projects that they run to improve our access. So I think it was a really good read for us. I think we read it. It read well. It does show that our patients, obviously, we can always improve, but we're starting from a really good position on access. Often I'm asked to speak on access, and one of the reasons might be because I think our surgery might be one of the best on access in the borough, if I'm right, in general. So we have a very easy access service, as does actually Dr. Danjal. We have different models, completely different populations, I would say, but the access is the key. Definitely, we know to patient satisfaction, the higher the access, the higher the satisfaction. I don't think access is the key to high quality, however. I think there are so many factors that lead into quality, but definitely what patients seem to want at the moment more is to see their GP where possible, as Nikki was alluding to. We don't want to have a model that breaks that up. And so, the different sort of presentations I've given on access, We've had to do a few nationally. I had to do one at the King's Fund the day the Fuller report came out. I'll never forget that day. But also I gave one last year at North West London to the PPG. I was asked to speak there to the patient group. We talked about the 3 key elements of access which are in part of this recovery plan. So that's the online, which is the digital approach. I know we have patches in our borough, but every surgery, of course, is slightly different. We have the telephone, the new telephony, and we have that now in every single surgery. Everyone sort of does, again, designs it their own way. And then we have clinical triage. I don't think that's just right in every surgery yet, but the senior doctor making a decision on the patient, which is the model that lots of us work, seems to make a really efficient, safe running service. And they're the models the national team are promoting. So I think that's really important to recognise. And they're there's a quality improvement team coming to each surgery. We've got funded time to make that happen. Again, our borough teams are chasing us for Excel spreadsheets to make sure that we've done it, which is good. Make sure it happens. So I think, we've got that already. If it's okay, I might say some of our concerns, if that's okay, which I think is fair. It's a scrutiny panel, so I guess I think that's fair. So I guess last year when I was brought to that meeting at North West London by Javina and our then engagement lead, Olivia, very useful meeting, patient group of goodness knows which number, but across the 8 boroughs to talk about the access recovery and to sort of describe the different models that we have. No one spoke about this model, the same day access. The same day access, actually, when you press 1, you'll be diverted away if you want care on the same day, and it won't be your GP seeing you. It might be in a remote hub, triaged by a non-clinician, by a care coordinator, to non-doctor roles. And you'd only see your GP if there's complex care. Now, I hear Andrew saying that this is going to be revised, and I'm really reassured to hear that. But it's just being mindful about what the actual anxieties were. It was less that it's going to be forced in a contract. It was more the principles and the way it was done. So last year at that NWL PPG very formal meeting where the ICB organised it and were present, it wasn't mentioned at all. However, it had already been decided behind closed doors. So I think that's one of the reasons why people have been concerned that these decisions have been taken about them, without them. And I think our borough, especially owe it to our residents to make sure that, as we can see from our earlier presentation around North Kent recovery, that we really owe it to our residents to do the best for them. And trust, I heard come up a lot in that previous part of the evening. So I think that's one concern. I think the other concern is, yes, exactly what this model is. So if this model is that you don't see Dr. Danjal when she knows you really well, and she can obviously sort your stuff out because she's known you for 15 years and knows your family and knows your medical history, but you do see someone who doesn't know you, maybe isn't medically qualified, hasn't got the correct supervision, then you are potentially putting your health at risk. And I think it was quite an uproar that happened when this model came out, but I think we can learn lessons from that. I think that hopefully we can, maybe part of today is meant to be that I think Joe was saying lessons have been learned. It'd be really good to hear what lessons have been learnt, because I think, again, doctors, patients having a voice and having a say on their healthcare is vital. I don't think any of us GPs realised how much primary care really meant to us. I don't think anyone realised. Really, we can't put, there's no number you can put on the soft stuff. When I heard you talking earlier, counsellors, to our colleagues at the front, I know what they get up to because my patients benefit so much from their services. And it's that human connection, which you can't, unfortunately, report back on a piece of paper. There were 400 people, yes, but 400 people really impacted by fantastic, high-quality services. And that really is, the essence of primary care. It's a human concept. We know our patients and we care for our patients. So I guess that was the other. And I guess if we think about, again, going back to the national uproar, I think now there have been something like 7 articles in the BMJ, almost weekly. The most recent one by Imperial College's public health professor. I did write down what he said. I'm sure you've all seen it already. But this is defragmentation of our healthcare services. And he's quoted the many other articles on North West London in the references to that, and they only came out last week. And then there's Dr. Helen Salisbury, who says, why are we levelling down? We should be levelling up. And I think West London is a really good example of that. We have it in West London. We need to lead. And I hear Andrew saying that We may not have all the decision makers in the room, but we have leaders in the room. And it would be amazing if West London, who are delivering well, yes, we have variation, yes, we can improve, but if we're delivering well, can we not help the other boroughs level up? Joe's nodding, so I'm assuming that is, something that we'd love to be able to do. And I think with your support and backing, I think we can go back to the ICB and say that that would be a really good thing. If we've got it here, is it right that we had the top outcomes in the whole of North West London for satisfaction? Is that right? Yeah, the top. That's really unusual. I know I speak too much. I'll stop in a minute. So I was just going to say a couple more things. So the other thing, we were told that this is nationally mandated. We've tried to get understand what that means. Now I hear it's actually North West London, it's not national, but that was the key reason why patients weren't allowed to be consulted on this. And I think that's really concerned lots and lots of people. So we've tried to get to the bottom of this. From conversations, we've spoken to Andrea Leadsom, who everyone knows who she is, and Amanda Doyle, who sits next to Claire Fuller in NHS England, and actually Amanda Pritchard herself. And Amanda Pritchard herself has said, when she heard about the model, she said, what about continuity? And that was her first reaction. The second one was when she was told this is mandated and that's why we're being told to do it. She said it's not nationally mandated, it's not from NHS England, and she can guarantee that it's not coming from their department. Amanda Doyle said the same thing. So I think we have to be really honest here about how this has happened, why this has happened. And I think going back to the drawing board is essential. I think that's what the LMC are doing at the present with the ICB, and I do applaud them for getting to this point where they can have those conversations and start listening. But I really think, me and Nikki are just 2 GPs out of 100 plus in our borough. We've got our opinions, of course we do, and I hope our opinions have been valuable. But what about all the other GPs who are experts on primary care and their voices? And then behind that, what about our is it 280,000 patients we have? 280,000 patients' voices behind our GP surgeries. Let's use this as there's momentum being built up with what's been happening. Let's use this to actually start engaging even better with our patients and maybe build in better co-production as we're seeing with all the community groups and really get patient voice involved here. Because I think we can learn lessons and we can really go forward and have even better outcomes for our patients. And that's not counting appointments, but that's high quality care.
Thank you so much, Yasmin. Cleo, I was just going to see if you wanted to add anything from a Health Watch perspective.
Yes, thank you. I'm so glad that we're here talking about this evening, because I think it's never been made so clear to us from residents and patients that we work with that an issue is high on their radar and on their priority list. So we've had hundreds of patients approach us because they're concerned about the proposals and because they'd really like to understand actually what's going to happen and how will they be involved in that process. The patients we've heard from, I think, have a wide variety of views on the proposals themselves and on what access should look like, but there's a few themes that have come through. One in particular is that people are telling us they don't feel that engagement is enough and they would like a formal consultation, and we've heard that it's not possible because of it being nationally mandated, but it would be good to unpick that, I think, a little bit, because that is what residents are telling us they would like to see. They're also telling us that they'd like to see evidence of efficacy. So we know that there's some PCNs that are trialling this already. They'd like to see the data, and patients are saying, if we're going to be consulted with or engaged with on this, actually, can we have some data about, is it effective? Can we see that? And the final thing is that they'd really like to see learnings from our existing system in terms of what's working well or not so well currently. So for instance, with the way that GP practices are currently triaging patients, how can we take learnings forward from that into whatever a new model might look like? So things like making telephone triage more accessible, for instance, for people who are neurodivergent or hard of hearing. These are the types of themes that are coming through. So we'd just like to understand more about how are those learnings going to be kind of incorporated into any new model. I think those are the key areas that I was wanting to highlight. Thank you.
Thank you very much. Do you mind if we sort of start taking... Okay, if you could, you respond and then we'll start questions from the committee.
I mean, just to make the point that those are very reasonable points, but they are around North West London strategy, so they really are kind of a JOSCI kind of conversation. So I can't answer lots of those. I think everything that we are saying around how we are developing the new service agrees with everything I think you've both said about more patient engagement, about understanding what works, and about taking things forward. Yeah.
I'm going to start with a couple of questions. This first one just is, I'd like to get your thoughts on whether same-day triage at scale is something you would recommend to West London practices from your perspective. I'll start with that.
So same-day triage is something that the PCNs will be able to explore themselves and make decisions around how they want to make that model work. I think for some practices it might well work. It's not something I think anyone is particularly recommending.
And then moving on, which we've sort of spoken about before, and I just want to say from the committee's perspective, we are very disappointed there's no senior member of the ICB here tonight, because I feel like you can't necessarily answer the questions, some of them that we will be talking to in terms of which might have applied to things in the previous months. So that's something I just want to state. And then sort of looking to, at the moment, the timeline of the next year, because something we did request from the JOSC meeting was the fact that we were going to receive a comms plan and an engagement plan. And obviously we spoke about a consultation, but that was very much pushed back on. That's something I didn't really see in this, and I understand you're now working at a PCN level as to how you're going to be moving forward and developing this. But given that sort of the next date we're probably looking at is next April, can you talk to us about how this is going to happen, how you're going to reach GPs and patients to get the right amount of engagement to ensure that you're going to be able to really understand what this service should look like? Thanks.
So currently the ICB is working with the LMC around how we create a business model to take this piece of work forward. So there's about £6.5 million which is accessible to North West London to support this work, and we have to come up with a business case that we can release that money into the system. So that is currently being negotiated at a North West London level and with the support of the LMC. So there will be various aspects of that which will be about supporting practices and PCNs on understanding their population needs, understanding how they deliver or don't deliver access in a good way locally, but also engaging with their patient and participation groups and on a wider level as well.
Portia, do you want to?
Yes, thank you, Chair. And thank you for this interesting report. I've got 3 questions for you. How far will patients be expected to travel if they're referred to a different practice? In your executive summary, you mentioned that this report will address the following areas of inequality. Now, I'm just wondering, how did you come to such a model? Did you consult with those with language barriers, mental health or disability? And also, it's very difficult to try and understand how you can develop such a program or your organization without consulting the most vulnerable, because they're the ones that are going to be needing and using the service. And how will you engage patient's choice and patient remain in the heart of your service?
Okay, so the model that's going to be delivered in West London hasn't been finalised yet. So we haven't had that conversation with PCNs around how they want to modify their access, if they want to modify it at all. So that will be a creative process with communities, with various groups and patients that access the service. So that's going to be an ongoing piece of work as we go forward. The improvement in access that we've done over the last few years has been done in partnership with PCNs, and they've engaged with their communities around how they deliver those services. So we've got a south and a north hub that we currently deliver services, GP's primary care services in the evenings and at the weekends, and that's based at St Charles and down at the Violet Meld Shed. Hopefully, that's not too far for anyone to travel, but I would anticipate one of the conversations that PCNs will be having with their patients is what is a reasonable distance for you to travel if it's decided that in your best interest you need to go and see a physiotherapist somewhere else, or you need to go and get your smear taken somewhere or a blood test taken. These are conversations that we expect PCN-CDs to have and to come up with some consensus.
And so you're not quite sure how far patients would have to travel?
We haven't asked people that. We haven't got a model to ask people that question about yet. But we've got the services we've got at the moment seem to be reasonably accessible and seem to give us fairly good patient satisfaction rates.
And can you guarantee me that whenever a patient would call, they'll definitely be triaged and seen by a qualified doctor?
Well, it depends what they want and what they need. So there'll certainly be a clinician making the decision about who's the best person to see them. So I know there was lots of worries in the past that there would be non-clinicians triaging people to non-clinicians. Now we have a wide range of people supporting doctors in primary care now. We have therapists, we have physios, we have pharmacists, we have counsellors, we have all kinds of people. Mm-hmm. So often it's the important thing is about getting to the patient to the right person as quickly as possible. So that's hopefully what the triage will do for patients.
The thing is, I'm sure you can understand my concerns because remember, people build relationships with their doctors.
Yep.
So if and when they don't see their doctor, they might not have the best care. They need to be able to, this service needs to be able to reassure patients that they're going to get the best possible care if and when it gets implemented.
So the concept of primary care teams is not a new one. It's been around for decades. This idea that your GP is supported by a range of therapists and a range of people. So I think that continuity of care is incredibly important, particularly to people who have complex conditions or long-term conditions, and that's something that other aspects of Fuller's Stocktake report addressed for the development of MDTs and INTs going forward. So that is something that's being addressed. This access piece of work is really about those people who, out of preference, want to be seen quickly and aren't particularly keen about or particularly fussed about which doctor they see, but they do want their problem dealt with quickly.
Sorry.
And we do know that is a section of the population. If you look at the rise of Doctor at Hand and other services, online easy access services are very popular with large sections of the population, not all of them. That's why we've got this variation of offer in West London at the moment.
Thank you. I've got more questions, but yeah,
I'm going to move to Mona, sorry.
Okay, thank you. I just want to start by saying, is this working?
Yeah, press that one, yeah, and then Lucy will switch on.
There we go, thank you. Yeah, I just want to say to Dr. Razak, just thank you for your intervention, because I know how difficult it can be sometimes and the courage it takes to kind of say the difficult things. And I agree completely, just from, it's difficult to kind of approach this exercise just from thinking about the context of the report itself, because really this is about the extreme anxiety that a lot of people are experiencing at the moment about the possibility of these interventions being imposed on local GP services without, forget even a consultation or an engagement exercise, just a basic awareness that it was happening. And I agree completely that this, all it's going to do is fragment the service, that it's part of a wider campaign to de-skill the service as well and allocate jobs that traditionally GPs or medics would have been doing, allocating them to those who aren't qualified in those roles. And I think, yeah, it's just going to take a wrecking ball to continuity of care based on what's been proposed already, which not only is that going to have patient safety concerns, but it's also inefficient. Surely having the person be seen by their GP is going to be cutting down on the workload. That's going to be significant inefficiency that we've introduced to the system by the possibility of having people see somebody that they're not familiar with. The other thing I want to mention as well is that I'm really concerned about how this could be implemented when we don't have the buy-in of the professionals who are going to be required to implement this. So you mentioned the fuller stock take, but we know that local medical committees and GPs have voted against similar same-day access plans are set out in the fuller access report. We know that GPs aren't on board with this. And I'm worried also about the impact that it's going to have on GP workloads and just the feasibility of supervising multiple hundreds potentially of patient interactions a day, having sort of overall responsibility and supervisory role in managing that. There's quite a lot to say, and I appreciate that this is JOSC territory. I get that, but this is essentially the only opportunity that we're going to get to raise these concerns that our residents have, and it's not at all shocking that nobody from the ICB is here. It's what I've only been a councillor a year and a half, but it's what I'm sort of accustomed to, that an ICB members don't attend. I've got a couple more questions about impact on health inequalities and the care coordinator roles and how that's going to be, what the governance structures are, and training that's going to be offered. I appreciate that all of this now is on pause. I actually don't know what's on pause and what is still going to be evaluated and rolled out. I don't know if we're ever going to see the outcome of or evaluation of the 10 pilot PCNs or practices that had piloted the programme, and whether or not that's going to inform what comes next. Surely that's a starting point before we, if we're going back to the drawing board, surely that's the starting point for understanding what's gonna come next.
I think Simon is keen to take your questions.
Yes, thanks very much. There's a couple of points I'd like to make. We were in front of this committee about a year ago because the committee was interested in hearing about primary care access in West London in a context whereby it is without question one of the biggest national priorities facing the NHS, and there is constant, very significant publicity, as we'll all be aware, of the fact that people find it very hard to get an appointment with their GP. So clearly something needs to be done. I don't think anybody would disagree with that. I'm assuming people would accept that improvements need to be made. So if we can set this in that context, I think that would be quite helpful. The status quo is not a realistic place to be. In West London, we have a fantastic track record of improving access to primary care. We've got very good satisfaction ratings, as you're aware. In terms of the ICB not being here, we are the ICB. So just want to be very clear about that. We're not the core North West London team, but we are the ICB, and we can speak for this initiative. We may not know every answer to every question. We can go away and find out answers that we can't give you here tonight, but we are the ICB. There's a lot of investment that's going to go into this programme. I want to be very clear about that. There's a lot of money going in, so it's not about in any way reducing services. And this is a model that is designed by very eminent GPs. I think it's very important to say that. I absolutely accept and respect the views of our GP colleagues here, but it's not managers in grey suits that have designed this model. This is GPs, this is doctors who work as GPs every day that have designed this model. So I think, again, that's an important point just to really make clear here. And I think part of the conversation reminds me about during COVID, how we were asked a lot of questions about people only being able to access care virtually. And in fact, it transpired that a lot of people were very keen on doing that. And they actually liked being able to ring their GP and to have a Zoom consultation. And I think that we need to bear that in mind here. For a significant proportion of the population, this will be fantastic because they don't care about seeing the same GP. The condition that they're asking to see a GP about probably doesn't require them to see the same GP. And so they will be able to see somebody more quickly and they'll get their problems sorted. It's for non-complex conditions for the most part that this is being put forward. So there are a lot of reasons why this makes sense. It hasn't come from nowhere. We've talked about it being in the Fuller report. In terms of nationally mandated, it's hard to really know what anybody means when they say that, but we're all expected across the country to be moving towards improving access and making sure that people can get through to their GP quickly and can see somebody on the same day if at all possible. That's what this is all about. Could it have been communicated better? Absolutely. Has the consultation or the proposed consultation be done as well as it might have been? Clearly not, and there are lessons to learn. But I think we need to hold on to what the intention is here. And, you know, the fact that this is about improving access for local people, and how we go about doing that might need to look a little bit different, but it's investment into frontline services for patients so they can get quicker access to their GP and or other relevant professionals. And I really think it's important that we have the conversation in that context.
I'm going to bring Gerard in. Mona, if you're okay, and then.
Sam, thank you for that. And I think you raise a really important point there, because to me this is about choice and how much the patient will have the choice as to whether they see their own GP or they get diverted off somewhere else. Dr. Tanjan, you mentioned that about separating patient care and the continuity. I think that's really important, and I just have this fear that the machine's going to take over, I'm going to lose that connection with my GP, someone will triage me somewhere else, and then the phone will get diverted there, I'll never get back to my GP, and I just have this image. I'm really up for what you're saying, and I think the next paper, when looking at pharmacists, I think there's been great moves there. I've had quite a few video consultations with my doctor, perfectly fine. But I'm really concerned about that ultimate lack of choice and who will make it. The second point I'm really just interested in is if somebody has a consultation, same-day consultation, not with their GP, and that then leads to ongoing treatment of a more complex, how's that? Because without sounding rude, we all know that people get lost in the NHS system, and the record keeping is not always the best it could be. So your word, I think, continuity is what rings with me. And do I have a choice of continuity, or is that going to be foisted on me? End of comment.
So I don't think it was ever the intention that patient choice would be removed. I think even in the very initial proposals, the patient would have access to go back and see their own GP. Now that proposal has been paused, but I think in any developing model, there would be an expectation that you would have the option to see a GP in your own practice if that was what you wanted, but you would have access to other services if that was more convenient for you as well. And it would be about how we made that work. I think the continuity is incredibly important, and one of the things that we are very aware of, that primary care tries to do emergency care, it tries to do continuity of care and long-term condition management, and it tries to do population health as well. So we're trying to work as an emergency department, as an outpatient department, and as a public health place, all at the same time with the same staff in the same building. And I think what we are trying to do is look at how we deliver those different bits of care, and how can we make them modern, up-to-date and safe. Continuity of care is a concern, and one of the things that we are working with is how can we develop integrated neighbourhood teams where we get the support of secondary care, primary care, other therapists, community care coming together to deal with complex patients in a team way, rather like we do with palliative care, or we're beginning to do with diabetic care, and we're doing it with cardiovascular care too. So it's all about supporting primary care to deliver community care in a modern way. So all of those concerns, I completely get them, but because we've got this opportunity now to co-design with our PCNs and with their communities what this model looks like, I think hopefully we'll be able to reassure everyone that we've managed those safety nets into the system.
I think for me what's important is who make, you don't need to come back to on this, but who makes that decision? Does my doctor make that decision, or does some faceless person in this system makes it? And the relationship with the doctor is an emotional relationship as well as a medical one. And I think I just would like you to reflect on that. Thank you.
I just wanted to ask a couple more questions, and I know Molly's got some more. What arrangements will be made for vulnerable patients with multiple complex needs on same-day access is the first one I wanted to ask.
So part of the triage process, if there is a triage process, would be that those patients were sent to the most appropriate person, which sounds, in the case that you're talking about, that would be their normal GP.
Can I just add a point to that, Lucy?
Yeah.
If you don't, sorry, Councillor Knight, if you don't mind. This programme will actually significantly improve services for patients of the sort that you're describing, because they will have more time with their GP, because their GP will not be dealing with the day-to-day patients who don't necessarily even need to see their own GP. That's the whole one of the whole principles underpinning it, is that GPs will be able to spend more time with their most complex patients with the greatest needs, which at the moment, unfortunately, isn't always the case.
But I think if you also spoke to GPs about that, and I think I'll bring Yasmin in on that, they would not necessarily want that. And I don't know if Yasmin wants to speak quickly to that, because I think it probably would be quite helpful for the committee to understand.
I might do. I think primary care relational continuity is so key. If I don't see those children when they've got their cuffs and their runny noses, I'm never going to know them when they've ended up with something horrendous happening to them, like a child protection scenario, which is what we have to deal with a lot, and build relationships with that family. So when they are in a difficulty, we're ready to help them when they do become complex, but also to prevent them becoming complex. So a lot of the minor work that we do, actually we have a holistic approach. So when they come in for X, we actually also deal with Y, and we also think about the family around them as well. That's the bit which is really distressing for GPs. We will not know our population. So when they become frail complex, we were never there along their journey or able to prevent them getting there. So we won't have continuity. We won't know our patients. And also, if GPs are just doing complex, there'll be higher levels of burnout. The registrars can't train with just complex. They have to build up to that over a number of years. So they will not be able to have the number of patients that they need to be able to become qualified GPs. We will lose our registrars. Imperial College training schools and the medical school are very much against this model, in particular because of that. And it's little things like that which maybe haven't been discussed with GPs or patients, which make this model not work. And the national leads who have designed this, I hear that this is a national report. There's also the Health and Social Care Select Committee report of Jeremy Hunt, which was obviously designed with GPs, and everyone backed that one, but not the Fuller report. And when I mentioned Amanda Doyle's not in favour of this model, Amanda Doyle sits next to Claire Fuller, and I've also spoken to Claire Fuller's deputy, who said this is not the model which we have to do. So I think we have to be mindful that, of course, we learn from all this data, but let's learn from local. Let's learn, if we are the borough who's the best in North West London for access, let's learn from that. We're already starting at a strong level. Yes, there's variation, and let's level up that and not remove access to our GPs.
Thanks, Yasmin. Simon, I don't know if you want to respond to that.
Well, I mean, the first thing to say is that clearly GPs have very wide-ranging views about this, as we've just heard. There is no consensus of opinion. I think that the NHS is faced with a huge workforce crisis, as we know. We have a chronic shortage of GPs. We're struggling hugely to recruit more GPs. And so, again, the idea that things can just continue as they are feels to me completely unrealistic. I'm not saying that this model is completely right. I'm not saying that everything that is in it as things stand it should remain in it, but I think that it is a good attempt in the first instance to try and improve services for local people in a context and environment where clearly the status quo just isn't a realistic place to be. So I would only say that. And
I just want to say, I don't think we're not against improving access. We want this to be done in a way that we can speak to GPs within our borough who are in support of it, because that is the only way it's going to work. If it's co-designed and in practice, yes, Andrew.
So I can sense there's a lot of fear and worry about this. The one thing we need to reflect on is that what we are already doing in West London is very similar to what North West London is moving towards. So we already have a system whereby GP groups come together to look after each other's patients. We already have a way where patients are triaged by 111 or by their own practices to go to different services. We already have therapists supporting GPs, whether that's physiotherapists, pharmacists, or other. So this is already happening, and it's doing very, very well. Yeah. So there isn't a big revolutionary change around the corner. We are really just trying to tinker with systems and make them better.
On that though, and this is from what Mona said to you earlier, then why, in terms of the pilots and the first early adopter sites, why are we unable to see the evidence of that?
Well, because we didn't have any pilots in West London, so none of our practices were involved in that.
It's very different to what has been heard that there were, and it would help this now if we were to be able to evidence what is being. But
so I think that's a JOSCI conversation, isn't it? Okay. And I think Genevieve is working about how we take that forward. Yeah. But no practices in West London were involved in the pilot scheme.
And then finally, and then I know Mona's got a couple more questions, just in terms of flexibility, and I know that you might not be able to answer this, but one of the things I did raise at the JOSC is the fact that one of the concerns of local GPs was that if they didn't opt in to this model, and I know we're speaking about it in a sort of what is going to be the model, they would lose 20 to 30% of their funding. And I just want to understand your mindset on the flexibility and how you would see this model operating if a surgery, for example, didn't want to be a part of it. And is that going to be a possibility?
So that is a JOSCI conversation, because that's made it a level much higher than me. The reason that the access requirement was decoupled from the enhanced service was to address that very issue. There is a desire at a North West London level to standardise the offer to residents in North West London. There is a desire to make sure that everyone has access to the whole range of services. Now, we've been very lucky because of resource allocations in the past that Kensington and Chelsea and West London have been able to invest a huge amount of money in primary care, much more so than any other bits of North West London. So I think there is a desire that we standardise things. Now, whether that means that eventually the access, whatever the access model tends to be, and as I say, it's still in the formative stage, is eventually coupled with the enhanced service, I don't know. But it would be, whatever happens is going to happen with the support of the LMC anyway. There's a strong desire to make sure that happens.
Okay.
Thanks. Yeah, I'm just still a little bit confused, because on the one hand we're saying that it's not very different to what's being offered already, but then on the other hand we're saying we're not actually in the process of delivering anything that's comparable to these same-day access hubs that can then be evaluated. I think the GPs who are involved in the same-day access hub pilots are themselves saying that they are concerned about the model and that they haven't had a sufficient opportunity to share their own learning, to review the practice, and actually that hasn't informed the development of whatever it is that comes next. I'm not even clear what that's going to look like. It's not clear at all. The fact that the pilots haven't taken place in West London isn't sufficient reason to not share that learning or to not evaluate that experience, whether it's the experience of the patients or the GPs that are offering it. I don't understand why we wouldn't have access to how the evaluation that was carried out, and that the feedback from that doesn't feed into the development of whatever it is that's going to be, whatever it is that's going to come next. It's nice to hear that GPs, I appreciate that medics have differing views, but I think it does need to be noted that the most vocal ones are those who are in opposition. Sure, certainly that's the voice that we're hearing consistently, and they're making some pretty valid points, whether it's via the LMC or in the media or those who are speaking here today. My understanding was that it was developed by an accountancy service rather than So it wasn't. So where did that come from? Where was that misinformation from?
So let me go through those points. The pilots didn't happen in West London, so we don't have access to any of their outcomes.
Sure, but their populations are comparable, right?
Well, so North West London, that's a North West London conversation, I would suggest. And I know that Genevieve and the primary care team at North West London are working out how to share that with the PCN conversations around how the borough models will work. So we don't have access to that. I think you're referring to the KPMG were brought in to support some of the pilot practices around how they understood. So they didn't drop in a model, but they did help popular PCNs work out what their need was, what their capacity was, what their activity meant, to try and do some business intelligence work with them. But they didn't drop in a model. They might have shared examples, international examples, but they certainly was down to the pilot practices to work out what they wanted to do. The other thing to say is that I completely get your point. There's a lot of passion around this, which is it's a huge compliment to all the clinicians and the communities that are involved, that they're that passionate about their primary care service, and that's very reassuring. But I have to say that most practices and PCNs in North West London have signed up to do this continuing piece of work. So although there's a lot of noise and anxiety in the system, which I completely get, there is also reasonable confidence in the process that we're about to go into, that we will come out with a good solution at the end of it.
What they've signed up to help inform the development of the service,
so
or
they've signed up to be involved in the next phase, which you will hear about at the JOSCI, I'm sure, when the business case is presented around exactly how that's going to work.
Yeah. Can I just finish by saying one thing that, as Councillor Knight was saying, it's not that we're saying things have to remain exactly as they are. I think it's a false dichotomy to suggest that it's either things stay exactly as they are, although it has to be noted that access in this part of London is actually really good, including for same-day access to your GP. Those numbers are actually comparably really good compared to other parts of England and other parts of London. But we're not saying it's either this or stays the same. Certainly improvements can be made, but it's whether or not they're the improvements that you happen to be suggesting. And regardless of this question of choice, you're saying that at the moment, for a lot of people, there doesn't seem to be choice. It's either patches or not seen for several weeks. And what people are saying is that they don't want a situation where that they're sort of pushed towards the option only of digital contacts because that's what I'm hearing, that they can't have.
What's in this?
Sorry?
I think the attempt to address access is to address that very point. How do we give back choice? How do we free up access in a way that populations can have a range of options, which includes face-to-face?
Yeah, and who's tasked with deciding or helping the individual to decide who it is that's going to be triaging that? Because I think it is a huge ask to be asking a GP, whilst they're focusing on these complex conditions, to then be supervising and having overall responsibility for hundreds of patient contacts from the care coordinators who are triaging out.
Well, as I said, we have models that deliver very similar services at the moment that are managed by local GPs and run by our local PCNs and CDs. And the conversation that happens next is how do we assess that and how do we take it forward?
Okay, I'm going to stop now.
Yeah, do you want to go, and then I'm going to go Josh, and then I think.
Yeah, I think as well as focusing on the evaluation of the pilots across North West London, there's also about how do we evaluate our model in West London, how do we evaluate both the in-practice individual delivery as well as the at-scale that we've been delivering that's kind of through our hubs at St Charles and Violet Melkshire, but also the sort of additional services like the urgent integrated care service. We have incredible outcomes from that. 90% of the people they see, they keep out of hospital. And focusing on the outcomes of what we're delivering and what we can build on is something really important to do. And I think we can probably gain as much, if not more, from doing that and building on that than from what some smaller models are doing in other parts of North West London, because the scale we're delivering on in West London is a borough-wide delivery, and that brings so many advantages if we're thinking about the workforce challenges, that's the support we're hearing that our PCNs and our practices want, and so that's what we're trying to build upon.
Josh.
Thank you, Chair, and I'm conscious I'm not a member of the committee, but I thought I'd use this opportunity to obviously put it on record on the minutes and just ask the ICB a few questions. Sorry, guys, I can't really talk and see you at the same time. I have met with Rob Hurd twice, Penny Dash once, and Dr. Genevieve Small once, and I put very, very similar questions that the committee has to it. In fact, I also followed up on a letter on the 17th of April, asking very similar questions on basically what all the committee has had an approach, and on all those 3 occasions, Chair, I've not received an answer. And this is in the fact of a few things, the communications of that and how that has been communicated to the wider community. Secondly, an explanation in plain and simple English as to why this is needed, because I think some of the reports so far have been very, very convoluted. Thirdly, this has never come to the Health and Wellbeing Board where the ICB has appeared, so it does not give an opportunity for myself or my colleague in Westminster or any of those other health partners to question the ICB on that particular panel as well, which is a decision-making panel for this part of London. And the fact that even though I have had a word from the Public Health Minister herself, Andrea Leadsom, that this is not in fact nationally mandated, this particular model on this part of London, and it may not affect this particular part of model of London. And I think we're putting the cart before the horse here. In a lot of aspects, what may work elsewhere may not necessarily work here. And there's not been a valid reason that I have had, as I said, despite 3 meetings and a letter, that have been forthcoming so far. And I think that's where my concern lies as well, because evidently this committee has a role to play, I have a role to play, and the JSOC has a role to play as well. And I think all those 3 parties aren't particularly getting a response that is satisfactory. Now, I completely understand that perhaps the model is not working at the minute, as Councillor Ahmed has said. And I'm conscious that some people are coming to GPs, perhaps that do not need medical attention or for very, very minor ailments that they could recover at home for. Let's say like a blocked ear or a sore throat. Perhaps that you don't need a GP necessarily to see. I'm very conscious of that. However, I think how it's being done and communicated, which I'm conscious the ICB has commented on, has been extremely poor. So all I'm trying to say is that I would like a response to those 3 proposals I have put forward, and hope the ICB will be able to follow that up and get back to me in writing as requested. Thank you.
Thank you, Josh. Any further questions from committee? I just wanted to ask one final question. That was, does the ICB have any proposals for a formal public consultation with stakeholders to ensure transparency and accountability? As I know this has come up a lot today, but just to understand that.
I think, as we've explained, there are no concrete proposals to put to public consultation at this stage. Work is ongoing, drawing on very wide-ranging engagement that's going to be happening over the months ahead. So it's far too early to say whether there would be any kind of public engagement required. The work's still underway.
But that's not saying a complete no at all. So it would sort of be reassessed along the way as to whether...
I think it all depends on where we end up with this. I mean, I don't really think I'd be wanting to say a definitive yes or no. I don't think it would be appropriate. But, the work's ongoing. I'm sure, very clearly listening to Councillor Rundle, there's a lot more conversations to be had on this. We can always come to the Health and Wellbeing Board. We'd be delighted to if we're invited to come and speak about this. We haven't been invited to come and speak about it there, but we can do. But, yeah, I mean, a definitive yes or no, I think, is probably not appropriate at this stage.
Okay. And in terms of your understanding what was asked for, are you saying before that the next time we will see actually formal proposals, engagement, kind of comms and also governance that were requested at the previous JOSC, we're going to see those at the next JOSC? Is that what you're saying?
It's not what I'm saying right now. I don't know what was said at the JOSC. I don't go to it, but I can very easily find out for you and get back to you with details of what the timeline is for this and when you will be in receipt of much more concrete and specific next steps and a timeline and all the rest of it.
Yeah, I think we would want that as a committee as soon as possible. And I, to be honest, I thought we would have it for this meeting, given it was requested a couple of months ago. But yeah, Portia.
Thank you, Chair. I'd just like to ask, can I just request that we'll see a diagram of a roadmap to a recovery strategy? Would that be possible for the service delivery process? The service you're proposing, can we have a roadmap?
Yeah,
we can see it visually so that we'll have a broader picture of what you're trying to offer?
Yeah, I think the point is at the moment there isn't a specific service that's being proposed. The conversations are ongoing. We'll be discussing it with GPs, with patients, with groups like Health Watch, and firming up during the months ahead what the service is that you're referring to. It's not defined yet. There's some broad principles that are defined, which people will be aware of, and we can certainly share those. But once there is more concrete proposals in place, then that's what we'll be sharing. And I think that's what I was saying to Councillor Knight. I will come back with a timeline for when that will be.
Yes, please. Thank you.
You're welcome.
And can I just comment on the time you've waited for the information? I think what that reflects is the sort of genuine nature from North West London about being honest about we are pausing and we are taking stock and we're reviewing. It's not paying lip service to the sort of concerns of GPs and residents. It is a genuine attempt to pause and reconsider before coming back with more firm, worked up ideas.
Thank you, and thank you for that. I think just generally as a recommendation, a report to come back to this committee with an update when appropriate and when those steps are taken. Thank you all for coming, and especially our GPs for coming and speaking. You made amazing contributions. Thank you. Moving on to agenda item 6, which is an update on community pharmacies in the borough. This report sets out an update to members on the community pharmacies in the borough and the implementation of Pharmacy First. We're joined by colleagues from NHS North West London ICP and the local pharmaceutical committee. Please, could you introduce yourselves? Thank you.
Yep. Thank you, committee. My name is Hitesh Patel. I'm the Chief Officer of Community Pharmacy KCW, which is the local pharmaceutical committee for KCW. Today I'm joined by Amish Patel, who is the chair and who is a local pharmacist. He's got a pharmacy in South Kensington. We don't have any representative from the ICB. And we don't have a representative for NHS England either. What I would like the committee to listen to today is about Pharmacy First. I think there's a lot in your pack today which gives all the details about Pharmacy First, which is a new service which started at the end of January. And it's an excellent service for patients. And we've talked about, patients trying to access minor ailments, minor acuity conditions without having to go to the GPs. And there is a lot of potential for pharmacies to help those patients. And I won't go into all the details because your pack has got all the details about the full service. But what I would really like the committee to hear today is that pharmacies will struggle to provide this service fully because of the workforce pressures that they're facing, but they're up to the challenge. So they can manage the challenge of workforce, but there are a few other things that I would like the committee to sort of receive from us. So the first thing that I would like to say is that, 10 pharmacies a week are closing in England at the moment. And in in KCW, we've had 8 pharmacies close in the last 20 months. So this, as you can appreciate, reduces access to healthcare and medicines for local residents. And pharmacies are the backbone of local neighborhoods. You know, the vitality of neighborhoods is reduced when you lose a pharmacy. And you know, when you talk about social isolation in the elderly, you know, my colleague here, Ramesh, will tell you that there are so many people who just walk into pharmacy just to talk to the pharmacists and the pharmacy teams, you know, and when you lose a pharmacy, you know, you lose that vital part of your neighborhood. Now, what we are expecting is to have across England 3 million consultations for the Pharmacy First scheme. But if all the pharmacies are closing, you know, what will happen is that you wouldn't have that vital link locally for pharmacies. Now, there's a couple of other things that I would like the committee to receive as well. One of that is that we might have a Pharmacy First scheme, which is really good, but there isn't any sort of anything in there for socially vulnerable patients. So patients on low incomes, you know, who might come into a pharmacy and they might get a good consultation, but at the end of it, if the pharmacist recommends a product that, you know, that they should buy, say for example, it could be for backache or something, and the pharmacist says that, look, I can give you this tube of cream, but it's £10, and that socially vulnerable person will not be able to afford it because they are the ones who have to decide between buying food or buying medicines. And what will happen in that instance is that they will end up going back to the GP and get a prescription, and they will probably not use the Pharmacy First scheme again. Or even worse, they might end up going to an urgent treatment center and try to get products that way. And we have numerous examples on a daily basis of this happening, you know, for over local residents. So it's important. I know that the committee might not have solutions to this, but there are solutions in other ICBs where they have sort of found solutions for socially vulnerable people. There is a few other issues that I would like to raise to the committee. One is that I know that it's a new service, but the number of GP referrals that we're getting into Pharmacy First service is pretty low. And I know that across Northwest London, other areas are having a lot more referrals coming into the Pharmacy First scheme. And I think it's something for the ICB to look at and see whether, you know, whether we can improve the referrals. Definitely we need better IT integration for these GP referrals to take place. So at the moment I can understand that it's quite tedious for GP teams to make referrals into the Pharmacy First scheme, but let's see if the ICB can make sure that, you know, we can improve referrals into the Pharmacy First scheme. And I've talked about, well, let's talk about the IT problems again. And it's there's several problems at the moment with the Pharmacy First scheme. Reporting to the NHS BSA, which is the payment body for NHS, that's a big, huge problem at the moment. And at the moment, pharmacies can't access GP records either, so which is vital. You know, if you want to give the right sort of consultation to a patient, you know, if you don't have the right records, you know, you can't give the right advice. So for some of the minor ailments, it doesn't really matter, but there are some now where, you know, we are prescribing antibiotics, and it's important that we have all the relevant records at hand. So that's just a quick run through of, you know, what Pharmacy First is, and then the challenges that we are facing. And there's one other thing that, and it's not in the papers, but there's one thing that I would like to mention while I've got the opportunity, is that residents in Kensington and Chelsea and across the country are facing real problems in accessing medicines at the moment, prescription medicines. There's a lot of shortages, and it's almost like medicine bingo. You know, patients are having to go to several pharmacies trying to find medicines, and these are regular medicines. So a pharmacy, a typical pharmacy might have about 100 different medicines which are not available, you know, and patients are having to come to a pharmacy and then to be told, oh, we'll try to get it for you. They come a few days later, it's still not available, then they're having to go to several different pharmacies. GPs are having to sort of reissue prescriptions so that patients are going to have to try elsewhere. So I think it's important for this committee to know that residents are really struggling to get their medicines, partly because of drug shortages and partly because the government is sort of not paying the right sort of money to pharmacies to sort of obtain these medicines at the right price. So there are several factors, but the main thing is that patients are struggling to get their medicines. So
thank you.
Thanks very much.
Thank you very much. Cleo, I just wanted to see if you have any contributions to this.
Yeah, well, I just wanted to say really that in terms of the feedback that we've collected from residents, it matches exactly what we've just heard. I think the residents that we've spoken to who are aware of Pharmacy First are very much in favour of it if they've used it. But residents are very, very concerned about closure of their local pharmacies. They're very concerned about the cost of medicines. And actually, when we've been engaging with people about GP access, a number of patients have told us that they wished that their GP had referred them into the Pharmacy First scheme. They were aware of it. They felt that that would have actually helped with access. So just really couldn't echo more the points that we've just heard in terms of residents' views as well.
Thank you very much, and thank you for this report. I think it also sheds light on some areas that clearly are of concern as to why this isn't working, maybe as effective as it can be. First area I just wanted to talk about was the actual referrals. As I spoke to some GPs about this, and they said one of the main reasons why they're not referring is that they sometimes it's sort of quicker and they feel safer to be doing the work themselves rather than referring it into the system. So from your perspective, is that due to partly just due to the system, or how can that be resolved? Because I'm sure if this was working and referrals were going up, then we would also be helping pharmacies in terms of staying open and yeah.
Yep. So I think it's entirely down to the capacity of the GP surgery. You know, if they've got enough capacity to handle all the minor ailments that come through their door, or when they're triaging, you know, then that's fine. Then they can manage it in-house. But I think the whole point of having Pharmacy First scheme and referrals into pharmacy for GP surgeries which are overstretched, you know, who basically, you know, can't give maybe same day appointments or within the next couple of days. And it's for that situation where, you know, the surgery may be struggling to cope with capacity. But if they can cope with the capacity, then there's no reason why they can't carry on. Some of the conditions, the patients can actually walk into a pharmacy directly for the 7 sort of conditions which are the clinical conditions. The patients don't have to go through the surgery, but any other sort of minor ailment type of conditions, they need a referral from a GP surgery for the pharmacy to actually treat it as a consultation. So I think we've heard that access in West London is good, so probably, you know, there might not be a need for GPs to refer into the Pharmacy First scheme. But I know across Northwest London a lot of GPs are referring into the scheme.
Andrew, Simon, or Joe, I don't know if you want to add anything to that.
The only thing that I've mentioned that I can't see in here is a special mention to the 9 pharmacies that are delivering COVID vaccinations at the moment. So up until each phase of the vaccination campaign, up until now, our GPs have been delivering through hub sites at St Charles and Violet Melchett that you heard about earlier. But for this campaign, they've stepped down, but the pharmacies have stepped up.
Thanks. Going to Gerard.
Thank you. Thank you very much for this report, and I think this initiative is an excellent initiative. I wonder, just in terms of pharmacies' premises, and whether there is a plan to upgrade pharmacies' premises in line with this. They do vary enormously, but it's not unusual to go in and see somebody waiting for an injection, and the pharmacist said, oh, hang on, we'll have to clear all the boxes out because they're using that room as a storeroom. And it's also quite amazing how much you hear people talk about their ailments in the general sort of customer area. So I'm wondering if, alongside this, there is a plan to upgrade pharmacists to have the proper facilities.
Good evening, councillors. Thanks for having us here today. To answer your question, we are so underfunded that pharmacy owners and pharmacy practices are not able to invest into their business for them to then invest in the infrastructure that they have. We'd love to have, bigger consultation rooms, a clinical bed in there now that we're doing these kind of referrals and seeing these patients in this capacity. But the true reality is that there is lack of funding for pharmacy, and because of this lack of funding, we're even trying to get medicines, we're struggling, and hence we can't invest in our businesses and in our pharmacies to make it where it should be, to be honest. I think Pharmacy First is just the first for pharmacy and what pharmacists can do for local communities and for the NHS in general.
Mona?
Thank you. So the report mentions that there's a 3,000, the cap for the number of consultations per month is 3,000. And I was wondering what number, how many referrals or how many consultations are happening per month at the moment, and whether the input from GPs being low, is that specific to GPs, or is it just in general the uptake of the service being low?
So the number of referrals or consultations that pharmacies are doing is going up gradually. Unfortunately, the data from the NHS is 3 to 4 months delayed, so we don't even have any data on the service right now, so I can't even tell you for sure how many consultations have been done locally or even nationally. Now, the upper limit of 3,000 I don't think will ever be reached. Really, the first target that pharmacies need to do is they need to do 30 consultations a month to get that minimum payment. So, but in the absence of GP referrals and enough walk-ins, then even reaching that 30 might be a target too far. But one would hope that going ahead with appropriate referrals, in 6 to 9 months' time, I'll be sort of telling you that yes, we're managing to do at least 30 referrals a month per pharmacy.
Okay, thank you. And there was just another question about, I guess, what work's been done to evaluate the confidence levels of the pharmacists themselves in providing this service, because it is quite a big ask, especially as they don't have the medical records, they don't have the patient's records to hand. I appreciate these are minor ailments, but it is prescribing nonetheless, and it just seems like a big ask of anyone to be making decisions when they don't have a patient's history to hand.
It's a valid question. At the moment, in terms of patient records, we do have access to SCR. So we do have the summary care records, which gives you the basic patient record, but we have to go into a different system to look at that. So ideally what we want is that, the patient records come up whilst you're doing the consultation, and that would sort of help matters. So it's not that we don't have any records at all. We do have access to SCR. Now, there has been a huge amount of training involved in getting in pharmacists ready for the Pharmacy First service, especially on-hand sort of clinical skills, like ENT skills, and every pharmacist that's providing Pharmacy First has had this face-to-face training for providing them the, otoscope training or, whatever sort of instruments that they might need to do. Even simple things like looking down a throat, using a tongue depressor. It's a skill that had to be learned because it's not something that pharmacists learn in universities. So everybody's sort of upgraded their skills to a level where they're really confident to provide that service. And there is a lot of information out there, a lot of clinical skills assessment out there, which pharmacists have been doing to skill themselves up. So I have every confidence in every pharmacist providing this service.
Okay, thank you.
Thank you. Portia.
It's very similar to Councillor Ahmed's question, but I would like to know, would you work collaboratively with doctors to review patients who are consistently getting prescribed the same medicine? How often would you do that? So would you ask for a review in certain medications if you find out that a patient is asking for a certain medication for far too long?
So yes, we can do, and in fact we used to have a service called a medicines use review where we used to do that, but that service unfortunately has come to a close now. We do that sort of review for new medicines at the moment, so which is a new medicine service where every time a patient's prescribed certain categories of new medicines, we do a full review and we make sure that the patient knows exactly how they're taking the medicines. But right now, there are pharmacists working within GP surgeries who do that sort of work, where they review medicines, on a regular basis and carry out clinical reviews of medicines. So, community pharmacies don't do it, but there are pharmacists working within GP practices who do that sort of work.
Thank you.
I just want to touch on, and I think we spoke about this at the JOS, but just slightly different angle, just on antibiotic resistance, and what can be done, because obviously in some cases pharmacies might be sort of incentivized to prescribe maybe when a doctor wouldn't. So how we're sort of managing, particularly with infections where it sort of repeat prescriptions, say over the course of years, can build up a resistance. How is there sort of training or how we're ensuring that that isn't happening?
So the key thing is that in terms of incentive, the consultation is what you get paid for rather than the medicine, because the medicine you're just going to paid for at cost. So you're not going to make a profit. So it doesn't matter if whether you dispense or prescribe an antibiotic or not. So there isn't any incentive to actually prescribe an antibiotic. But I would let my colleague Amish sort of fill in a bit more on that.
So with regards to the Pharmacy First training and our ongoing training, we have antimicrobial stewardship where pharmacists see the prescribing of patients and the antibiotics that they are being prescribed, and we're making sure that the antibiotics being given out and dispensed by us is appropriate for that patient and for the condition that they're being treated with. There's a lot of cases where there are antibiotics being prescribed that are not at the correct choice for the ailment that's being treated. So pharmacists, when we dispense and we give out antibiotics to patients, we actually look at that, and our pharmacy training that we do ongoing needs to show that we are doing that. In terms of the Pharmacy First service, we have set criteria and pathways as to when and when to not give out antibiotics, and for the service to really work, all pharmacists has to be mandatory to give out antibiotics with those set criteria. So, for example, one of the ailments is UTI, urinary tract infection. If the patient has had previous infections, say within the last 6 to 12 months, and they've had antibiotics previously by a GP, we are not in the position to actually re-prescribe that, and we'll have to refer that back to the GP for further investigation.
And the sort of records are, I feel like that came up in the report, but the pharmacist would see what they had been prescribed, that's all working together in terms of or planning to be integrated?
Well, that's what Hitesh was mentioning about this SCR, which is summary care record. So pharmacists can have access to patients' GP records. Yes, it's a very basic record, but we are able to see the ailment, the conditions that they're suffering from, what medication they've been prescribed in the last 12 to 24 months. And we kind of look at all that before we make the final decision as to yes, we can go ahead and give out antibiotics or not. And that's clear, that's very clear in our pathway for the service.
Okay, thank you. Mona, do you want to ask one? Okay. I think, unless there's any further questions for anyone. Oh, yes.
Yeah, I just want to touch on a few things that Hitesh said in his introduction. In terms of pharmacy closures, we, as mentioned before, especially in our borough, we're in a very difficult situation because our costs are ever increasing, rent is ever increasing, and we would love, as Councillor Gerard would say, love to invest back into our businesses, back into the practice, because that basically gives better outcomes for patients in the community. So if there's a way that the council can look at maybe even helping us with business rates so that, we pharmacies in particular have a bit of give so that we can invest back into our pharmacies, that would be amazing. I myself is at risk of closure. I think some of the councillors might know me from Stickland Pharmacy and the fact that there's a TfL redevelopment of South Kensington Station, and I'm heavily affected by that. And it's just disappointing that pharmacy closures are happening, but I think it's more happening in our area purely because of the financial burden we have in the area.
Josh, do you want to respond to that?
No, it's a really good point actually around that point around the South Kent point as well. I know that the planning inspector approved the development of that site, much to obviously the council's initial rejection of that, and it's going to have a wider impact on that as well. But I'm really happy to look at the wider aspects of that. I can't comment right now because I don't know all the complete details, but that's a really good point to raise, and I'm happy to follow that up as well.
Thank you, Amish and Hitesh. And I think we really hear what you're saying, and we can speak to the lead member further and work as a committee to support you, because I think we can all agree here that, and it's been said already tonight, that the pharmacy is the backbone of the community and can help relieve pressures from GPs too, and we want to work to get all of this system right. So we'd love to keep in comms, and if you can keep us updated, and thank you very much for this report, and just to check that the NHS don't want to say anything further on this. No.
Thank you, Councillor.
Thank you very much for coming. And let's move to agenda item 7, which is the work programme report. This report is an update on the work programme and scrutiny activities, setting out reports for upcoming meetings. Committee members are asked to consider areas for the work programme for 2024 to 2025 based on the review of the last municipal year in Appendix 2.
Thanks, Chair. Just to make a couple of points, as you just said, we're at the end of the municipal year, so it would be excellent if members could start to think about priorities, key challenges, areas which should be taken forward for the next year, which we can feed into the work programme. And just secondly, because I think it has come up in tonight's discussion, it is the case that we do have joint health scrutiny arrangements with other boroughs, but just to reiterate the point that you are very much still a sovereign committee with sovereign powers in terms of health scrutiny, and you're very much empowered to bring reports to this committee as well. Thank you.
Thank you, James. Anyone got any comments?
We do seem to have a lot of reports that were waiting to come back, or that can we have an update of any reports that we're waiting for, and or updates of the updates? Not necessarily now, but just
Yeah, of course, yeah, we can bring those forward.
Anne.
So, James, I probably just don't understand the process here, and I can see that we've got something down for the next meeting on the 10th of July, but normally we have a kind of plan where everything's laid out.
We're doing a workshop.
So, so what's the process to get to
So what the process looks like is that the OSC lead on the work programme, they've put together a workshop for this committee, which is on the 17th of June. But at the same time, we have to start planning and thinking ahead for the next meeting, which is on the 10th of July. So as a committee, you'll be asked to say you're in support of the two reports which are proposed. One is around the community diagnostic centres, the other is around immunisations, which I know a lot of the members have a lot of interest in. So we'll take those forward for the 10th of July, and then we'll develop, as you said, a more complete work programme for the rest of the year on the 10th of June.
And does that then come to the 10th of July for us to...
Correct, yeah.
Yeah, and there's the workshop is on the 17th of June, is that what we just said?
Yeah, sorry, the 17th of June, yeah.
So that's
an OSC, that's not for us.
That's an ASC.
Yeah, sorry, so it's for members of this committee, but we work in conjunction with the Overview and Scrutiny Committee as well.
Any further comments? If not, that concludes this meeting of the committee. Thank you everyone for your time and attendance this evening.